Okay, and we are live. Hello, web shadowers. Thank you all for joining our session this afternoon. Today we have the pleasure of hosting Dr. Khanna, who will be teaching us about ophthalmology. As always, please remember the Google form will be posted in the chat box and in the description of this video at the very end of the session. With that being said, Dr. Khanna, you can get started whenever you're ready.
Hi, everyone. Am I audible? Hopefully. I'm Dr. Khanna. I'm an ophthalmologist currently in Maryland, so I'm going to be hosting the ophthalmology shadowing session today. If you have any questions along the way, feel free to post them. I think they're going to reach me through some forum, and I'll be able to answer them as we go along. And I'll start with a little bit of information about what I do and about myself. So let's see here. So basically, currently, I'm a cornea and external disease fellow at the University of Maryland. In order to get to this point, my training has been kind of a compilation of different locations. I did a 7-year undergraduate with medical school program at Temple in Philadelphia. So that's where I was for 7 years, followed by a year in Philadelphia again at Pennsylvania Hospital for my intern year. And I did my 3 years of ophthalmology residency at Brown in Providence, Rhode Island. And I'm about 3 months from being done with my fellowship. It's a 1-year fellowship after ophthalmology. So just to give some background, I think ophthalmology is very often overlooked. As you'll see, depending on what stage you are in your process towards medicine, you'll notice if you're a medical student that you really don't get a lot of lectures in ophthalmology. And even as a pre-medical student, it's not one of the fields you often hear about. So for me, I mainly learned about ophthalmology as a third-year medical student because I had the opportunity to do an elective in it. And that's kind of where my exposure began. And I kind of decided late relative to many others to pursue it. But no regrets. So I'm a cornea and external disease fellow, but that encompasses a lot of different things for ophthalmology. So basically anything on the outside of the eye. So as you visualize the outside of your eye, the white part of your eye, the cornea, anything surface related kind of falls under my specialty. Refractive surgery is a large part of cornea. So that includes LASIK, PRK, and believe it or not, most of what we do in our fellowship is actually cornea transplants. So I do a lot of different cornea transplant procedures. And then ultimately, once I finish training, I'll be doing a lot of cataracts as well, just like any general ophthalmologist would. So it's really just the surgical clinical management of the external eye, along with pretty much anything a general ophthalmologist would do. So I figured I would start with basic eye anatomy because the eye can be pretty abstract for a lot of reasons. So here you'll notice from front to back is kind of how this picture goes. So we have the cornea, which is the clear anterior portion of the eye. And then you'll notice the iris, which is the colored portion of the eye. Sclera is often referred to as the white part of the eye. You'll hear people refer to it as that. And of course, the pupil is the visual axis that basically exists between the retina through the pupil and then through the cornea. Here in the back, you're getting a little bit of a view of the retina here. You'll appreciate the optic disc, the optic nerve over here, the macula, which is the primary affected part of the retina in certain conditions like macular degeneration, diabetes. And then this is just kind of a cross section showing the different layers of the retina, just as an overall schematic. So most of what I do kind of focuses on the front of the eye. And believe it or not, there's a specialist for pretty much every aspect or part of the eye. So we have cornea as a fellowship, retina as a fellowship. There's neuro-ophthalmology, pediatric ophthalmology, oculoplastics, which is more about eyelids and the skin around the eye. So we really have all of our bases covered by several different specialists. So a little bit more about my territory. So the cornea, again, is this highly organized, transparent dome-like structure that basically covers the iris, the pupil. It forms the anterior chamber, which is basically the space between the cornea and the iris. And it's part of our focusing and how we're able to see. The cornea is made, again, very highly organized. It's about 80% water, it's stroma. So that helps it to maintain the clarity that it does throughout the day to help us see. And the cornea basically receives its nutrition from tears and the aqueous humor. So it's actually quite avascular. And in order to remain transparent, the endothelium of the cornea, which you can appreciate on the back side of the cornea, actually serves as a pump to remove any excess fluid. So I just listed some items that I really appreciate in my field. For those who are pre-med or in the early rigors of medical school or at any stage really, there are a lot of things to look into before you choose a specialty. And it kind of becomes easier to understand actually retrospectively now that I'm looking back. And when you're kind of in the midst of it, you end up choosing what sits the best with you and what fits you the most. So looking back and now looking forward, these are my favorite things about ophthalmology. So there's a lot of variety in procedure, a lot of variety in specialties, as I mentioned before, all of the different fellowships that exist. The surgeries are generally quite shorter than your general surgeries that you see in medical school, usually on the spectrum of less than an hour, and the longest surgeries being closer to 2 hours. It's a procedural field. So if you realize that early on about yourself that you like being hands-on, that might be something that's appealing. But it's also a field that can be as medical versus procedural as you want. There's still a lot of clinical procedures that can be done, not in a surgical setting, or many providers choose to be primarily medical, meaning that they don't do surgery. So you can kind of make it whatever you want. Another appealing aspect is once you're out of training, of course, the schedule becomes pretty standard in terms of what to expect for your hours. And the call is pretty bearable, especially in private practice. So I'm looking at a question right now. How long is your internship and residency? So internship is 1 year and residency is 3 years. It used to be pretty much up to last year, it was 1 year of medicine and 3 years of ophthalmology. But now it's becoming a 4-year program that's categorical. So basically, once you match where you do for ophthalmology, that's where you're going to be going for your intern year. And your intern year now across the board will have some involvement with your opto program. So you'll get LinkedIn earlier, basically, rather than doing your intern year somewhere separate like I did. You're able to specialize within ophthalmology as a medical student. So basically through the match, like any other specialty. Our match is actually earlier than match day for everyone else. So medical students who are applying to ophthalmology match in January of every year. So that's pretty much when you're able to specialize in the field. Is basically standard compared to the others, except the timeline is a little quicker. That's pretty much the only difference. So another question, do I work at a medical hospital? So I'm a fellow, so I'm at University of Maryland, but I will be pursuing private practice after this. And that's one of the great things about ophthalmology. You can kind of do both. You can do private practice, you can do academic, or you can do a combination. The difference between ophthalmology and optometry, there are several differences. We work super close with optometrists. They are an asset to any of our practices. Optometrists go to optometry school for 4 years. And then obviously ophthalmologists will be going to medical school for 4 years. So it's very different in terms of training. And then after that, optometrists have a optional residency that they can pursue for a year or two. And then again, I went through after 4 years of medical school, an ophthalmologist will do 4 years of residency. the only difference, the question is the only difference between ophthalmology and optometry the surgeries? I would say no. There are several differences based around what we focus on. So I think generally speaking, ophthalmologists handle complex eye disease, really sick eyes, and when the pathology gets a little more complicated, definitely they handle all the surgeries and procedures, and that's what we're trained to become capable of through residency. And then optometrists have a large focus in refractive error, contact lens. They even get involved in medical. Some people go to medical residencies and learn how to manage complex ocular disease so that they can work side by side with an ophthalmologist to see the same patients. So there's a large variety in what we both focus on. Right now, probably the biggest difference is surgery and procedures, but a lot of our focuses are really different also, depending on what we narrow our focus on. So this is, again, the path. I already explained it, I think, verbally, but basically it's an undergraduate degree for ophthalmology, a graduate degree, an MD or DO, an ophthalmology residency for 4 years, and then an optional 1 to 2 year fellowship. That is completely optional. You definitely don't need to do a fellowship. There are plenty of amazing general ophthalmologists who do way more than anyone can even imagine. But there are several fellowship opportunities. And if you have any other questions about like timelines and what kind of the process is closer, I listed SF Match as an amazing source because that's our agency that handles our match. So sfmatch.com kind of gives you all of the information there. So considerations, again, at every stage, you always want to consider having a good mentor or several good mentors, always having an eye out for research opportunities or getting an early involvement into research, especially for applying to residency and fellowship. That becomes particularly useful. And with any specialty, extracurriculars, hobbies, that's all still important. So finding and achieving that balance in medical school will really, help you to kind of broaden your horizon and help you figure out what it is that you enjoy the most. So I have here some cases. I will definitely leave it to you guys to fill in what you think about them. But again, if you have any questions throughout the presentation, feel free to ask and throw them my way. So my first case, I have a 16-year-old female who presents with 2 to 3 days of extreme right eye pain, light sensitivity, and tearing. So as a question, I have, what would you ask this patient, or what questions would you want to ask this patient? Does anyone have any thoughts about that? Any thoughts on this case? So I will proceed because there might be a little lag as to questions. So if anyone comes in with eye pain, especially a 16-year-old, yep, when did it start? That's a good question. Medical history. Those were already my top 2, so that's good. So medical history, you want to know if the patient has any medical problems that might predispose them to eye pain, any ocular history. So we always want to know, have you ever had any surgeries? Like someone mentioned, did you injure the eye? Trauma? Do you use any eye drops? Has anything changed near your eye? Particularly with a 16-year-old who's coming in with one-sided pain, we always want to know, are you wearing contacts? Are you around anyone with similar symptoms? Because that might insinuate a different type of etiology, like viral, bacterial. Along with medical history, you want to know if anything's changed in someone's health. So fever, chills, is it one eye, both eyes? Because that'll make you think of different causes of their eye pain. And then if the patient wears contact lenses, how are they with their contact lenses? Are they removing the lenses every night? Are they being compliant and adherent? Do they use a solution every night to take them off? Or when they take them off, are they wearing daily lenses? Are they wearing monthly lenses? So that's all really good stuff to know. So basically, I have these questions here. So medical history, none. The patient does wear contacts. Not around anyone with similar symptoms, no fevers, no chills. The right eye is the eye that's bothering the patient. And the patient reports that she sleeps in contacts most nights and hardly washes her lenses, or cleans them, rather. So in order to really assess this patient and to figure out how serious this issue is, we have to do a complete eye exam. So when you first come to a patient with an eye complaint, these are pretty much the fundamentals. These are the elements of an exam that constitute a complete eye exam. So often what we will do for every patient. So our vitals for our eye exam is the vision of both eyes, eye pressure, and pupil exam. And when I say vision of both eyes, I mean usually the best corrected vision. So what is the best that patient can see? So usually if they have glasses with them, I like to know what they can see with their glasses. The eye pressure, you'll notice I put a little tono pen. It's a device on this slide, on the right of the slide. So that's actually a device we use to measure the eye pressure. There are several ways to measure the eye pressure, but that's just one of them. And the eye pressure, there's a huge range as to what's normal or can be normal for certain patients. Generally speaking, 8 to 20 is a normal eye pressure, but there are variations to that. And of course, for the pupil exam, we want to make sure the pupils are reacting. There's no APD, which is an abnormal pupil exam. We also want to make sure the extraocular movements, color plates, and confrontational visual fields are intact. Color plates in particular will give us a sense of the patient's optic nerve function. So often if patients have an optic neuropathy, that might elucidate something. Confrontational visual fields are great, especially in, for instance, stroke patients. You can sometimes pick up on a visual field deficit and be the one making the diagnosis of a stroke. And of course, our eye exam, which is the external slit lamp exam at our slit lamp, and a dilated retina exam. So this patient's exam, she is 20/40 in the right eye and 20/20 in the left eye. So she's a little more blurry in the right eye. She has a normal pupil exam, normal eye pressure, and her eye movements are unremarkable. Her confrontational fields are unremarkable, and her color plates, she's able to see every color plate. So I will be showing you guys the external slit lamp exam on the next slide, but of note, her dilated retina exam is unremarkable. So here you can see, I'm not sure if you can really appreciate it on your screens, but basically on the left side, you see the eye is a little injected, it's red, there's some teary discharge, and there looks to be some type of a defect on the center of the cornea. You can't really make out exactly what it is, but it doesn't look white or dense. It's almost like a clear defect. When you instill fluorescein drops, which we use all the time in cornea clinic, under a cobalt blue light, you can appreciate the right photo over here that basically shows significant fluorescein uptake in kind of a circular shape on the pupil. So now that you've seen this photo, what kinds of diagnoses are you thinking about? I'll give a few minutes. I know there's some lag between. Okay, so that's a reasonable. So one person messaged infection from contacts. that theoretically could completely be possible. Are there any other thoughts as to what might be going on? Okay, a torn cornea. And I'll go over some of the terminology we use. Corneal ulcer, absolutely. That could totally be what's happening. So those are all really good ideas. Scratch cornea, absolutely. Good. So actually, I'll go into, and bacterial infection could absolutely be true. I'll go into some of the terminology just to give you all a little more knowledge into how we describe the different pathologies in the cornea. So I have a differential list here. So basically on our differential is a corneal abrasion. So a corneal abrasion is essentially a scratched cornea or a torn cornea. I saw both in the message box. So basically an abrasion is a scratch on the eye that is not associated with an infiltrate. An infiltrate would be like a white density on the cornea that would be more suggestive of a corneal ulcer, which is also what someone mentioned. So those are both really, really high things to consider. And someone who's sleeping in their contacts and not cleaning them is maybe they have an abrasion, maybe they have an ulcer. So those are the two top. Of course, we always think of uveitis, like an inflammation in the eye, or a conjunctivitis, which could totally be the case as well. With conjunctivitis, we usually think of a bacterial versus viral etiology. So I have here kind of a process of diagnosis and how we go about coming to the diagnosis. So on the photo I showed you guys, the initial one here, I'll pull it back up. You can appreciate on the left photo, there's no real dense white infiltrate on the eye, which is a little more suggestive of an abrasion than an ulcer. So that's what I mean by the no clear infiltrate. Also, I wrote that poor contact lens hygiene really places the patient at high risk for an abrasion or ulcer, which all of you have guessed. And there's no discharge or injection of the eye otherwise to suggest conjunctivitis. So usually with conjunctivitis, like a bacterial conjunctivitis, you'll have a lot of mucopurulent discharge. Sometimes it'll be bilateral, sometimes it'll be on one side. Usually if it's viral, like a pink eye, you'll have more watery discharge, but usually the story is that it started in one eye and then went to the other, as I'm sure you may already be familiar with in just general life. And then there was no inflammation on exam to suggest a uveitis. That's usually a finding on slit lamp exam. So for corneal abrasion, we treat with antibiotics. I know many of you suggested an infection. That is exactly what we want to prevent. So this patient has a scratched cornea and we want to make sure that they don't develop an infection. So we use erythromycin ointment typically 2 or 3 times a day for a week, along with Vigamox, which is a moxifloxacin drop that we prescribe 4 times a day. For a week, generally speaking. We advise the patient to not put their contact lenses in at all until they have healed up, and we give them the clear. And we review contact lens hygiene, which is usually to remove your contacts every night, to use proper cleaning solution every night, and to minimize your risk of infection if you are predisposed to sleeping in them, to maybe switch to daily contacts so that you can take them out and just throw them out every day. And then we would have this patient come back in a week. So that's generally kind of the course of a corneal abrasion case. Does anyone have any questions for me for that? Before I go into the other case, I think there was another question from someone that I can answer now. The question was, did you consider optometry versus ophthalmology? And if so, what made you pick between the two? So I actually did not. I was already in medical school when I decided to do ophthalmology. So that's, that was the route for me. I guess in order to make, if you were to choose, you would have to choose between the two before pursuing either track. So probably before medical school would be ideal if you were going to go into optometry. But I was actually already a 3rd-year medical student, so the option for me was pretty much to go through with ophthalmology track. There's a question in the message box. What is a good substitute ointment if the patient is allergic to erythromycin? That's a good question. Often we can use bacitracin, kind of on the skin around the eyes. If the patient is allergic to erythromycin, we may just not use an ointment and just have them use the Vigamox drop and just see them in a week. The ointment is kind of more for lubrication than it is for the antibiotic properties anyway. So we may just keep the ointment off, to be completely honest. The next question is, what's the difference between iritis and uveitis? That's a really good question. I don't think there actually is a difference. We use the word iritis though in a separate way of uveitis, just mainly for distinguishing between diagnoses. So for example, you can have a traumatic iritis, which is inflammation in the eye from trauma, and you can have idiopathic uveitis. It's just kind of phraseology, but there actually is no difference on exam. The finding on exam for iritis and uveitis is basically seeing what we call cell and flare in the anterior chamber. So you'll usually see some inflammation in the anterior chamber for either of those diagnoses. And we kind of use those words interchangeably most of the time. Yes, you can have a uveitis without it affecting the sclera, or it can affect the sclera and you can have a sclerouveitis. So those were all really good questions. There's also a question, what does the fluorescein uptake signify? So that's a very good question. Let me go back to that picture. So you can appreciate here on the right picture, the fluorescein uptake centrally. It's pretty impressive. You can even see it with the naked eye, like without the microscope. What does fluorescein uptake signify? So it signifies epithelium breakdown. So wherever the cornea has been affected in terms of the epithelium, you will see uptake. So it is not really necessarily good or bad, but it demonstrates that the epithelium has been violated. So I guess in this case, it basically signifies bad because it's showing you that that abrasion has affected the epithelium substantially. Probably close to 70% of the epithelium is affected in that photo. So yeah. Oral medications for an abrasion, not usually. We very rarely use oral antibiotics for infections unless we're concerned that it would become systemic. Usually abrasions will respond really well to topical therapy like ointment and drops. Sometimes we bring in the oral antibiotics if we're concerned for an infection around the eye. So like a cellulitis or inflammation kind of around the orbit, then we definitely get into systemic antibiotics. So I will go on to the second case, but feel free to keep asking me any questions. I'm happy to answer. So we have a 35-year-old male this time who's presenting with light sensitivity, clear discharge, and extreme discomfort of both eyes. So what questions do you have for this patient? And again, I'll give it a few minutes because I'm sure that the questions will come through. But this patient is a little different than our first because he has light sensitivity, clear discharge, and extreme discomfort of both eyes. He's a little older than our last patient. Not by much, but good. So family history, you want to know, does he use contacts? How long has his pain been there? Totally all good questions. So let me see here. Is he on any medications? Of course, that's really good. Allergies, those are all very, very good questions. So again, I'll bring over my general history. So we want to know, does the patient have any medical history? Are they on any medications? Have they had any eye surgery? Have they had any trauma to the eye? Are they on any eye drops? Do they wear contact lenses? That's still important. You know, you can still have bilateral eye pain and wear contact lenses. It doesn't always have to be one eye. Is the patient around anyone with similar symptoms? I think someone mentioned a family history. So particularly zoning in on, is this patient around any family members or any kids, little kids with similar symptoms? That becomes really important. Believe it or not, and another good question to ask is, has the patient been around any kids who go to daycare? Because sometimes kids who go to daycare pick up some eye infections that are very easily contagious. So that might give you a clue as to what the patient has. We always like to know any fevers, chills, the timing of symptoms. So I think someone had asked that. Of course, that's a great idea. We need to know how long this patient has been uncomfortable. And again, if he wears contacts, how is his contact lens hygiene? So you guys did really good with that. So he doesn't have any medical history. He doesn't have any ocular history. He does have a daughter who's 2 years old who goes to daycare. He doesn't have any fevers or chills, but he's reporting that he had symptoms in his right eye and then it went to his left eye a few days later. And I'll add that he's had symptoms for about a week, roughly, at this point. So again, with just presenting the vitals of the complete eye exam, so vision, eye pressure, pupil exam, extraocular movement, color plates, visual field, slit lamp, retina exam, all of those things are still critical. We may not necessarily expect a lot of them to be positive. For instance, this patient should basically have the normal color plate test, but just to be thorough and make sure that we're getting everything, we do the full eye exam. So this is the vitals. So we have a patient who's seeing pretty close to perfect. He's seeing 20/25 in both eyes. He has a normal pupillary response. His eyes are briskly reactive, normal eye pressure. They're moving appropriately. He has good confrontational fields. For confrontational fields, just to review, if anyone wasn't sure, that's basically when we check the peripheral of a patient's vision using our own fingers. So often you'll use 2 fingers in the periphery of their field and have them tell you the sum of the sum of the fingers that you're holding up. External slit exam, which I will show you in the next slide, and then the dilated exam was normal. So for this patient, imagine both of his eyes look like this. You can appreciate he's super red, super injected. There looks to be some clear discharge, not much mucopurulent white discharge, but very, very injected in both eyes. So at this point, what are you guys thinking about in terms of a differential? And I'll give again a few minutes because I know there's a little bit of lag time here. Good. So infection from his child, viral conjunctivitis. That's great. That's a great thought. Does anyone else have any pink eye? Yep. So pink eye is also like a viral conjunctivitis. Is that the main one? That might be what most of you guys are thinking. I'll just give it a few more minutes. Good. Okay. So that seems to be what everyone's thinking, and that is definitely the top of our differential. So viral conjunctivitis, like we kind of went over, it's also called pink eye. So for anyone who said either of those, yes, that they're essentially one and the same. Pink eye is kind of like the common term we use, but viral conjunctivitis is a very reasonable thought given that the patient has a little kid who goes to daycare. He had symptoms in one eye that went to the other eye. So that's very reasonable. Also, a bacterial conjunctivitis would be a reasonable thought, even though the patient didn't have a lot of mucopurulent discharge. That would be reasonable. And then scleritis versus episcleritis. So scleritis and episcleritis are basically injection redness of the white part of the eye, like I had demonstrated in the beginning on the photo, the sclera. So that's definitely something we think about also when we have a patient coming in with red eye. So the process of diagnosing this patient has no medical history to really suggest a reason why they would have like an episcleritis or a scleritis. Sometimes, even though most 50-50 chance that a scleritis or episcleritis could be idiopathic, a lot of times there is a autoimmune etiology kind of with it. So it's less likely that it would be these. Also, the episcleritis, scleritis type of category doesn't usually present like one eye contaminating the other or one leading to the other. That's not usually what we see. And it's usually pretty rare to see a bilateral process of a scleritis and episcleritis. It's definitely possible. Usually most of the time you'll see it on one side. And then another process of diagnosis we go through is that this is less likely a bacterial conjunctivitis because there's no mucopurulent discharge. So this patient had more watery discharge, which was more suggestive of a viral etiology. So you guys did great with that. I always like to ask about a patient being around little kids, a patient being around anyone who has similar symptoms is another way to ask it. But those are all very good thoughts. So treatment for viral conjunctivitis, this is what patients don't like to hear because there's really no medication that makes it go away. The treatment for viral conjunctivitis or pink eye is actually completely conservative. So the recommendation is lubrication, artificial tears, ointment, just to kind of help the eyes feel a little more moisturized. Antibiotics are typically not given. Sometimes they can even make the symptoms worse. So generally, if we feel very confident that it's a pink eye, we won't be dispensing antibiotics. We always advise patients to wash their hands. It's super contagious. We let them know that, especially if they have little kids. We want to make sure that the daycare knows that, the child or the child's parents have this. We always recommend washing sheets just because the viral particles can kind of spread that way. And we also always tell patients it usually gets worse before it gets better. And that it resolves around 2 weeks, like a 2-week time period. So usually it gets worse before it gets better, but usually by 2 weeks, we should be on the mend of recovery. So I have a few quotes that I came up with on my own, kind of to end this talk and kind of to open the floor to any questions people might have about the process of medicine, what my journey was like, what training was like, depending on what stage you're on in your career or what you're thinking about. So feel free to leave those questions here at this time. I have several quotes that kind of, for me at least, instill a lot of positivity and are really helpful reminders that I wish I got every day of my training. So I will go through those, but as I see questions, I will answer them. So my first quote that I want to toss out to the group is, don't give up. There are always going to be times when you feel like giving up, but trust that there are better times ahead. So that literally applies to every stage, whether you're in college or you're in a post-bac or you're in medical school or in between schools or in residency or fellowship. There are going to be a lot of trials and challenging days that make you feel like you're not cut out for what you're in, but always remember that it gets better. And with every tough year comes a better year. So just always stay optimistic in that regard. So I have some questions about the last case that I'm going to go over. Let's see here. Do you use antibiotics as a treatment for bacterial conjunctivitis? Usually still topical. So still a topical Vigamox drop usually and an erythromycin ointment. But if we have any concern for the surrounding of the eye, then we may consider an oral antibiotic. What is the reason for more contagious spread in young children? That's a really good question. It's not actually the fact that the kids show less symptoms. It's just that by virtue of kids being around a lot of other little kids in a daycare setting or a playing setting, they just contracted a lot easier between each other. So a lot of times you'll hear of an adult who has these symptoms and they'll kind of mention like, oh yeah, my daughter, my son has similar symptoms. That's the only real connection with the kids that I make. Are there any severe symptoms of conjunctivitis besides the inflammation? So conjunctivitis is usually patients are very uncomfortable. They have very like significant light sensitivity, a lot of watering of their eyes. They can hardly open their eyes. It's just really uncomfortable. But there's no other severe repercussions. So usually these patients recover quite well back to normal, really. And most of the time they don't experience any long-term changes in their vision. But that's a really good question. And then some questions about the journey. Okay. So do you feel as though you missed some college experience doing a joint BA MD program? Yeah, that's a really good question. So I definitely, you'll see, I kind of post a lot about this on my Instagram too. It definitely is not for everyone. So I do not recommend a joint BA MD program for everyone. I think it can be really great for the right person. For me, I always knew I wanted to do medical school, so I wasn't really using college as a time to figure it out. And it actually, the joint programs often will kind of give you like a GPA and an MCAT to meet, such that if you get the GPA and MCAT, that you're pretty much guaranteed a seat in admissions, which for me was really comforting, and I really liked that. At the same token, that obviously made college a little more stressful because you're trying to complete all of those courses in 3 years rather than 4. The way Temple did it, my college degree still relied on some of my classes in medical school. So I didn't have to really finish a 4-year degree in 3. I just got my undergraduate degree after 4 years. So my medical school classes actually kind of finished my undergrad degree. So I definitely don't think it's for everyone. It is a little more pressure to kind of get everything done in 3 years, but it can be super great to kind of get a jump start and maybe even use that year you saved somewhere down the line for traveling or whatever else, maybe even another degree, depending on what your interests are. So I definitely think that it's not for everyone, but it definitely has its pros and cons for sure. Let's see what else we have. Oh yeah, and missing college experience. For me, I don't think I did. I feel like I had a pretty ample college experience. I didn't get to travel abroad, but I think I could have with the program. It didn't stop me from doing it, but obviously there's just like a lot going on. So I wasn't able to do that. But I definitely really liked my medical school class and the friends I made. So I didn't really feel like I missed out. When was the hardest point of your medical journey, and what do you wish you heard during that time? So that's a really good question too. I would say my hardest point in my medical journey was as an undergraduate student and a pre-med student, honestly. I think it's really difficult to understand what you need or what schools are looking for when you're an undergraduate. I think a lot of times also the coursework doesn't feel as relevant to medicine. So sometimes that's a little discouraging. For instance, like for me, I wasn't really a fan of physics or organic chemistry particularly. And believe it or not, you honestly really don't see much of that after the first year of medical school. But it can be discouraging because that's what's all over the MCAT, and that's what your course load is based on as an undergraduate. So I really think that it's important to remember, like medical school, the courses are not what you're taking in college, and they're a lot more applicable to real life. They're a lot more clinical. They're a lot more relevant to the human body. A lot more anatomy, a lot more physiology. So it's just important to remember that the pre-med courses are essentially kind of like a rite of passage, but are not at all really in line with what you're going to see over the 4 years as a medical student. Let's see. So my Instagram is someone asked where you can reach me. So you can reach me at my Instagram is probably the best way because my email will be changing soon once I finish fellowship. My Instagram is eye.am.tasha.md, and it'll be on the last slide. So it's I am Tasha MD, and you can totally reach out to me there. And I post a lot about all stages of medicine, or I try to. And I'm always looking to be inspired for new content. So if you have anything you want to hear about, just give me a shout out, and I'll definitely reach out. And then let's see, have you ever dealt with imposter syndrome? Of course, as a pre-med, as a medical student, as a resident fellow, the imposter syndrome never goes away, unfortunately. But you just have to trust yourself, and you have to believe that the training you've had has made you capable of the next step. So at every stage, you're kind of going to wonder whether you're cut out for what you're about to take on, but it's important to just trust the fact that you've gone through all the right steps, and just give yourself some credit. Let's see. Is there any risk of going blind partially or completely with any of the diseases discussed today? So that's a really good question. Corneal abrasion, if you do not treat it with antibiotics, can develop or progress into an ulcer or a more visually threatening condition. So that possibly could. We definitely recommend urgent evaluation for any sudden onset of eye pain. But yes, a corneal abrasion, if it's not treated adequately, can progress and can create some more serious eye infections for a patient. Viral conjunctivitis, since there's no real treatment aside for conservative treatment, if a patient just sticks it out, it'll usually go away in 2 weeks on its own. But again, these patients are so uncomfortable that most of them do end up seeing someone in the interim. Can you explain how poor contact hygiene leads to a corneal abrasion? So sometimes if a patient doesn't clean their contacts, a lot of times bacteria will linger on the underside of the lens and kind of incite a scratch or incite an infection. The abrasion is actually more a result of lack of removal of the lens. So sleeping in contacts, the percentage is super high of a patient's risk of contracting an abrasion or an infection. So sleeping with contacts is actually what led to the abrasion in that case. But the fact that the patient doesn't clean their lenses is what can predispose them to an infection, if that makes sense. So an abrasion might be more mechanical, like you're sleeping with your contacts and rolling around and kind of mechanically disturbing your cornea. But the hygiene relates more to a patient's risk for infection. Let's see. So if you were to go back in time, would you stick with ophthalmology or choose optometry? So for me, I picked ophthalmology once I was already in medical school. If I could go back again, I personally would go back to medical school and do ophthalmology all over again. I really, I love the surgical part of ophthalmology. On top of that, I love cornea. I've become really passionate about cornea transplants. I just love the procedures and the real complexity in eye care. So for me, I would definitely do it all over again. Yes. I knew pretty early on I wanted to be a doctor. That's another question. I kind of knew going into high school, which is abnormally early, but that's why every person's path is really independent and specific to them. So you just have to be true to yourself. And that's about it. How competitive is it to match into ophthalmology? So sfmatch.com has great statistics, better than what I would be able to just say from the top of my head. It is, I would say, one of the more competitive specialties to apply into. It's definitely not the most competitive, and it's definitely not the least competitive. It definitely is more on the higher end. And SF Match has great data as to who's been matching in the last, I think they have data going back like over 10 years. So it's really good to see, kind of gives you an idea of the spectrum of who's been matching. In terms of Mcat preparation, which is another question, when I took the Mcat, it was the older Mcat. So probably doesn't relate to you guys anymore. If I can give you any advice for the MCAT, it's, limit your resources. That goes for any board exam that you'll face in your medical career. Don't get bogged down by like 10 different companies trying to teach you the MCAT. Just find one you like and stick with it. And you'll go far. The MCAT is different than when I took it. I took my MCAT, I would have to say I took it early 2012. So several years ago. And I know the format and the scoring has changed, but my best advice to you would be give yourself time to study and don't go crazy with buying every resource. Find a good Q bank, find a good set of questions, and find a good, like a good text that you can really read easily. And don't get bogged down by how many resources there are out there, because there are just so many. Let's see. Do you need to go into medical school to then go into internship and residency to become an ophthalmologist, or can you go into optometry school and go into internship and residency? Yeah, so in order to become an ophthalmologist, you have to go to medical school and you have to do a 4-year residency. Optometry, you do not have to go to medical school. You go to optometry school and then you do optional years of training thereafter. If you are not looking to be a surgical person, then optometry may be more for you. But they're different paths entirely, like very different in terms of the number of years you have to go through. With medical school and residency, you're looking at about 8 years and then an optional fellowship. Whereas with optometry, looking closer to 4 to 5 years. So it really depends on what your passions are, if you're restricted on time, or if you prefer to be done by a certain point. All of that kind of plays a factor. Let's see. Any advice in terms of obtaining medical experience hours for medical school? I know there's been a lot of limitation with that with the pandemic. You guys are doing great by attending virtual shadowing sessions. I would just start reaching out to practices. They may be more amenable to having pre-med students or med students come by. I know hospitals are still being a little restrictive in terms of visitors and students, but generally things are starting to open up. So hopefully you can kind of find some more opportunities now. You can also reach out to anyone who you would like to talk to in any specialty, and maybe you can work out something where you shadow virtually or otherwise. But I know it's been a real challenge with the pandemic. Let's see. I'll just see if there are a few more. We're coming up on time. So long-term side effects for laser eye surgery. Laser eye surgery. So laser eye surgery is a really broad term. There's a lot of different laser eye surgeries. So we have LASIK, we have PRK. There's a new procedure called SMILE, and there's even laser cataract surgery. So there's always there are so many different laser surgeries. The most commonly spoken about complications or side effects are kind of variable depending on the laser procedure. With any procedure in any specialty, there's always a small risk of infection and the need for more procedures. And that's always what we tell patients. And then, does having an astigmatism affect your eyesight significantly was another question. Depends on how bad your astigmatism, how high it is. Several people live with astigmatism and don't have any trouble with it. But if you have a really significant astigmatism in a direction that is less easy to get used to, then it can be it can kind of warp your vision a little bit more. And we have contact lenses that exist to treat astigmatism, of course, glasses. So there are a lot of options for that. And I'll leave you guys with a few more quotes. And then again, if there are any other questions, but I think we're going to be finishing around 5. So let me just go through these here. Another big message I want to send all of you is tune out the negative energy, focus on your goals. Always listen to yourself. You know what you need to do. And if you don't, you know how to figure out the answers. So that's a really important message. Try to tune out anything that gives you bad vibes and just kind of try to focus on the positive, because in medicine, you'll always encounter some negative energy from just general competition. And it's important to always tune that out and focus on what matters to you and what your goals are. And then, like I mentioned, actually, when someone asked about the MCAT, so limit your resources. Like buying every book, having every book and every tool does not necessarily mean you'll do better. Sometimes it's super overwhelming to have every resource. So really just delve in. I often will look at so many websites to figure out what the best resources are for a certain exam. And I'll limit myself to 2 to 3 max resources. And that's honestly helped me tremendously. And again, don't let anyone tell you you can't do something. The only person who can really tell you that is you, or the only one who can stop you is you. So that is my final advice, I believe. I think there are a few more questions and then we'll finish. So would shadowing a primary care physician be more beneficial than shadowing an optometrist for preparing for ophthalmology? Honestly, I think shadowing either. Optometry, if you shadow an optometrist, you'll see a lot of what we do. So you'll definitely get a good insight into our exam and how we conduct an exam and what we look for. So it's very, very useful to shadow an optometrist. We actually shadow optometrists in the beginning of our residency in order to get an idea of how to obtain an eye exam adequately. Primary care doctors are always good to shadow just for general medical knowledge and understanding how systemic conditions relate to the eye in this case. And what advice do I have for first-year students interested in ophthalmology? So I assume that might be a first-year medical student. I'm not sure if that would be a freshman in college. So first year in medical school, I think if you already are interested, it's definitely great to start reaching out to people in the department at your school to see if they can link you in with any research activity, any clinical activity. If you have your first and last summer in medical training after your first year, if you actually have a serious interest in ophthalmology, it's a good time to get involved with the field. I personally wasn't thinking ophthalmology at that time, so I wasn't involved with it. But I think it's a great time after first year, if you already know, to kind of get your feet wet and see if there's any research opportunity or clinical opportunity with your department. Again, this is my Instagram, so if anyone has any other questions, feel free to reach me there. Thank you so much for attending, and I hope this was educational and a great opportunity for you to learn about our fields. So thank you.
Thank you so much, Dr. Khanna. We really appreciate you coming to speak with us today and for taking the time to answer all of our questions and for such wonderful advice. We really appreciate it.
Yeah, no worries.
For everyone still watching, the Google form has been posted in the chat box and will be posted in the description shortly. And you have 30 minutes from now to fill that out. And once again, thank you so much, Dr. Khanna.
Thank you guys so much.